When I see a person,
Okay, so let us start. Let us start today. So we'll be starting with diagnosis of syphilis. So I think I've seen one or two questions about this, and I feel we need to pay attention to it. So there are two forms of tests that we can use to
we
diagnose it.
can't see. Sorry, we can't see your screen.
Oh, sorry.
And are you recording?
Yes,
Yeah.
I am. Can you see it now?
Yes. Thank you.
Okay. So two tests, the serologic and the direct. Serologic, direct. So the direct, that means we are just dealing with that organism itself. We are is either we are doing the analysis of the DNA of the organism, or we are looking at it directly on a microscope. So we'll talk about that one later. Let's concentrate on the serologic ones. So serologic one means that we are just dealing with serology, antigen antibody interaction. So not that we are looking at the organism directly. We are either looking at the antigen of the organism, or we are looking at the antibody. So any one of them, that's serology. The serology testing is now divided into two: the non-treponema and the treponema. So the non-treponema means that you are looking at antibody antigen interaction that is not specific for treponema. The treponema serology testing means you are looking at anti-treponemal antibody and antigen. Now let's take them one by one. So what are the non-treponema serologic tests? There are two: the venereal disease research lab test and the reactive plasma reagent test. The rapid plasma reagent test. Now, both of them, they are similar. The only difference is that in the RPR you are adding carbon atom in order to make the test result very obvious. Now let us start with the VDRS first, so that we can understand what is happening, because once you understand the VDRL, you get what is happening in the RPR. So the venereal disease research lab test is just a form of serological test that consider or utilize antibody interaction with antigen. Now the antibody we are using in this video array is actually anti-cardiolipin antibody. Anti-cardiolipin antibody. That anti-cardiolipin antibody can be present in so many conditions. That is why it is a non-treponemal test. One of the conditions is syphilis. So what we do is that we just kind of incubate cardiolipin. So beef cardiolipin, that's the antigen. Beef cardiolipin. Once you inoculate it with the serum of somebody that you believe is having syphilis, there's going to be a reaction. So that reaction is in form of flocculation. So there will be foaming. So what you do is that you get the beef cardiolipin, which is antigen. You get the serum of someone that has syphilis containing the anti-cardiolipin antibody. Once you mix them together, there will be a reaction. There will be a foam reaction. That is your VDRL test being positive. So that means that if you can obtain a serum that contains anti cardiolipin antibody, you obtain a positive VDRL test. And it is not only syphilis that contains that anti-lipin cardiolipin. We are going to talk about the other organisms later. So the difference between that and RPR, which is the rapid plasma reagent, is that in order to now look at the result, you don't need to use microscope to look at the foam like in VDRL. For RPR, you just need to add a carbon atom to that mixture such that the foaming, the flocculation will be evident without need for microscope. That is it. So that means that we can say that VDRL and RPR are essentially the same. Do we get that?
Yeah.
Okay. So that is that about the non-treponemal test. Now, we are saying non-treponemal because we have some other condition that can, you know, test positive for this condition that is not syphilis. So the code is PVDRL, PVDRL. So the P is standing for pregnancy. So anti-cardiolipin antibody is also present in someone that is pregnant. V, viral infection like hepatitis B and hepatitis generally, hepatitis B, C, as well as infectious mononucleosis from Epstein-Barr virus. So anybody that has infection with Epstein-Barr or hepatitis, they tend to have, high amount of this anti-cardiolipin antibody. People that are using some medication like chlorpromazine and prokinamide. So the way I remember these two drugs is that I just picture them as drugs that can cause lupus, because I know that lupus too is positive for this VDRL. So once I get to the D and I'm trying to remember the drugs, I remember, okay, which drugs are actually with lupus? Chlorpromazine, prokinamide. Then the R is rheumatic fever, although it's very rare, very, very rare, unlike the other ones. Then the L is two disease condition. Lupus, anti-cardiolipin antibodies there, as well as leprosy. Leprosy. So lupus and leprosy, we should not forget that. Rheumatic fever, drugs, viral infection, and pregnancy. So these conditions are also positive for VDRL as well as RPR. So those are the non-treponemal serological tests. Now, what are the treponemal serologic tests? So that means that in this condition, we are not looking at an antibody that is not specific for treponema. We are actually looking at anti-treponema antibody. So the tool that we use that involves this technique includes our fluorescent treponema antibody absorption test. So that is the FTA ABS, fluorescent treponema antibody absorption test. Then the treponema palladium um, agglutination. So the treponema palladium particle agglutination test. They are very easy. So what we are just doing in summary is that we are taking um, the treponema palladium organism as a whole. So we just get the organism from somewhere. We can culture it maybe in rat or something. They have it. So that is the source of the antigen. We get the whole, organism, that's the antigen. Then we mix it, you know, with the serum. So the serum is first attached to an absorbent. Then we dilute the solution with the antigen, which is contained the whole organism. Of course, there's going to be a reaction. So in order to visualize that reaction, we had a, a fluorescent probe. So that fluorescent probe is going to emit light once there's a cross-linking between the antigen that contains the whole organism of the treponema palladium and the serum of the patient that has the syphilis. Because the person, will have produced the antibody against the treponema palladium because the person has syphilis. So if you mix them together, there's going to be a reaction with that antigen that contains treponema palladium organism. So your fluorophore can detect that interaction and it will emit light. So it will be fluorescent. That is your FTA ABS. The reason why we are saying it is specific for treponema is that the antibody that we are looking at, that we are testing for, is anti-treponema antibody, not anti-cardiolipin antibody, which is not a treponema specific antibody. Then similar principle also happens for our TTPA. So just get the antigen, we mix it, but the antigen is not the whole organism. We just get a particular protein of that treponema. We are not incubating the whole organism as in FTA. So you are just getting a protein particle of that treponema. You mix it with the serum of the patient. So there's still going to be an interaction, but you can visualize the agglutination. You are not using fluorescence. You just see the agglutination on your microscope and you make your diagnosis. So that is TPPA. Both of them are specific. And they are serologic because you are looking at antigen antibody interaction. But for direct testing, we are not looking at antibody antigen interaction. We are looking at that organism itself. So how can we look at it? Two ways. Dark field microscopy. So we just use maybe electron microscopy technique to look at the organism in a dark field. So it's a specialized form of microscopy that allows us to see that treponema palladium in a dark field. That is it. So it's a form of direct test. Why the other one is PCR. So we are very familiar with PCR. You just get the culture that contains the organism. You obtain the nucleic acid there. Then you run it. You run the sequence of the nucleic acid to know if it's compatible with what you have for syphilis. So if it is, then you make a diagnosis. That is a direct one. You are looking at the organism directly. You're analyzing the organism directly, not you basing it on seroconversion of antibody or antigen. Is it clear to us?
Yes.
All right. So the
So is
VDR,
the FTA ABS the same as the TPHA?
no, they are different. They are different, but they use the same mechanism. Your FTA, what you are doing there is that you are using the antigen component of FTA is the whole organism of treponema, the whole organism. You obtain the whole organism, then you culture it with the serum. Do you get that, Dr. Francois? So you know that
Mm-hmm.
the serum of that person is going to contain antibody against treponema. So if you mix them together, there's going to be an interaction. So that interaction is going to be detected by your fluorescent probe, which is going to emit light. Then you can say that the test is positive. Do you get that?
Okay.
But for your
Yes.
treponema pallidum particle agglutination test, your TPPA, you are only using a protein component of your treponema pallidum. You are not using the whole organism. It's not the whole organism that's been obtained. It's just a protein component that can,
Um. Sorry. Please finish.
okay, the protein component that can interact with, the antibody in the serum of the person. So because it's still, that protein you are obtaining is still part of your treponema pallidum. So it will still interact with the antibody in the patient's serum. And you can see the agglutination that is happening. Then you say your test is positive. So you don't need any fluorescence to look at that.
So the TPPA is also the same as the TPHA, rather.
The TPPA,
TPPA is also
okay,
TPHA,
which one is
right?
TPHA?
That the treponema pallidum heme agglutination test or something antigen. I don't know that that's what it stands for. I mean, I know about a TPHA for syphilis. So
Okay,
because
yeah,
I'm not seeing TPHA here, I was wondering which one was the same as the TPHA. But from
yeah.
what you've
So
described, it seems like it
yeah,
to be the TPPA.
it will be that. It will be your TPPA. It will
Yeah,
be that.
yeah.
So that is it. Yeah. So I think it's clear to us now.
Yes, it is.
Okay. So let's go to chlamydia. So chlamydia is one of those organisms that we have mentioned before, as the organism that doesn't contain cell wall. So it has a cell wall rather, sorry about that. It has a cell wall, but that cell wall is very low in muramic acid. So the peptidoglycan is not as strong as what you have for a typical gram positive. So it's very difficult to gram stain because of that. Chlamydia has different species. So we have Chlamydia trachomatis, which is the common one that we are familiar with. We have Chlamydophila pneumoniae and Chlamydophila psittaci. So Chlamydophila pneumoniae and Chlamydophila psittaci causes atypical pneumonia. So that is that about them. That's all they do. They just cause atypical pneumonia, and the way you transmit them is by inhaling the aerosol droplets. So you guys know that anything that's related to a respiratory tract infection, majority of the time it's transmitted through inhalation of the aerosol droplets. So we keep, those ones for now. But before I leave, Chlamydophila psittaci, from the name, is gotten from birds, particularly parrots. So from the name psittaci, P, parrot. So that's the kind of the vector that contains, or the reservoir that contains that Chlamydophila organism. Parrot. So someone that is exposed to parrot, can have um, um, contact with this organism and can develop, atypical pneumonia. So maybe the parrots have their excreta somewhere, or their droppings, and person inhales it as aerosol. The person can develop the Chlamydophila psittaci from there. So let's go to the other one, which is the Chlamydophila trachomatis. So Chlamydophila trachomatis can cause a lot of things. It can cause trachoma, which is from the name trachoma. So trachoma means follicular conjunctivitis or granular conjunctivitis. So the way you remember or identify trachoma is just to look at that eye. You guys know that when we say conjunctivitis, that means that's the inflammation of the conjunctiva. The conjunctiva is two. We have the bulbar conjunctiva and the palpebral conjunctiva. So this is the palpebral conjunctiva, the one that is located within the palpebrae of the eyelid. And we have the bulbar conjunctiva, which is the one that is within the bulb of the eye, like the eye, the whitish part of the eye. I hope you guys can picture what I'm saying. Like the conjunctiva that is lining the cornea, that is a bulbar conjunctiva. The one that is within the eyelid, like this is a palpebral conjunctiva. Do you guys get that?
Yeah, we do.
All right. So when you see something that's looking like follicles or granules, you know, with reddish appearance of the conjunctiva, you can say that this is follicular or granular conjunctivitis. And you can see that this is not only associated with swelling or redness of the conjunctiva, there's associated gritty substances that are deposited there. So this is what you have for trachoma. This condition actually happens in low resource setting, like um, countries that have high rate of poverty, like Africa. Why? Because one of the ways someone can get this is through flies. So flies can, you transmit the organism from one hive to another hive. So get the flies, settling down here, picking up the organism, transmitting to someone's hive. The person rubs the hive, inoculate the organism there. They can develop trachoma. Another way is by using unwashed towels. So I use the towel to, clean my face. The person face has that trachoma. Another person use it, they get the infection. Chlamydia trachomatis. And we are already familiar with the other spectrum of disease that chlamydia trachomatis can cause. It can cause PID. That's the commonest one that we usually say. It can cause PID. It can cause urethritis. It can cause reactive arthritis. So, we said it when we were talking about the reactive arthritis that chlamydia trachomatis is high yield when it comes to reactive arthritis. You want to watch out for that. Please, we should not forget. Once you see the question talking about conjunctivitis, urethritis, arthritis, you know that is reactive arthritis. The most common organism responsible for that is chlamydia. They will even tell you in the history that this person is sexually active. Chlamydia trachomatis. So that means that somebody can also obtain chlamydia trachomatis from sexual transmission. So when somebody has a sexual contact with someone that is infected, they can get chlamydia trachomatis. And that chlamydia trachomatis is going to be causing problems within the genitourinary tract, like pelvic inflammatory disease, urethritis. They can cause reactive arthritis as well. Now, in neonate as well as in the adult, they can cause follicular conjunctivitis. In the neonate, they will not cause follicular conjunctivitis. They will cause neonatal conjunctivitis, which you call neonatal ophthematorium. So this is the second condition. This is the second organism that causes neonatal of nanatorium. Uh, Neisseria
Ophthalmia neonatorium, Neisseria gonorrhea.
ophthalmia neonatorium. Take note of as well. So this is the second organism. Neisseria is the first one. Chlamydia trachomatis is the second one. So that is called neonatal conjunctivitis. We should not forget that. So they can cause urethritis, which is non-gonococcal urethritis. They can cause PID. They can cause reactive arthritis. They can cause trachoma or follicular conjunctivitis. They can cause neonatal conjunctivitis. So let's talk about the organism itself. So that's about what it causes. What about the organism? The organism is an obligate intracellular organism. That is, it cannot survive outside the host. It is obligate. Once there's a problem with the host and the host body is not getting enough nutrients, it dies. It doesn't have biosynthetic pathway to make its own ATP. It is dependent on the host. So they have to be with the host at every time, especially when they are metabolically active, so that they can survive. So once you take them out of the host, they die. It has two forms in which they replicate. Two forms in which they replicate. The elementary body as well as the reticulate body. So I feel we can get it from the first letter. So elementary body, it is smaller, it is denser. They have rigid cell wall. That form, they have a rigid cell wall so that they don't desiccate. So that form can actually be outside the host, but it will be metabolically inactive. So that's why I said when it's within the host and it is metabolically active, if the host is not getting nutrients, it will die. But if it's outside the host, it will want to be metabolically active. It's going to assume that metabolically inactive state so that it won't die off. So it will assume the elementary body form. So in that form, it's metabolically inactive and it can survive outside the host for a while. So that is the form by which it enters or gain access to the host. Entry. entry, elementary. E enters, E, just like what they have, shown us here. So elementary body form is a form by which the chlamydia organism enters into the host. So by the time it enters into the host, they change to the reticulate body. The function of the reticulate body is just the proliferative form. So that's the metabolically active form. So that one replicates using the biosynthetic mechanism of the host. So all the nutrients it's getting from the host, it replicates with it by binary fusion, divide into multiple forms, and later they will change back to the elementary body. Then the elementary body ruptures the cell and they can escape into the environment, or they can escape into semen, or they can escape into the vaginal epithelial cell, depending on the mechanism or the modality of spread of that chlamydia at that point. So that means that if somebody wants to spread chlamydia trachoma through a towel now, that towel is going to be containing which form? What form do you guys think that towel will be containing? Is it the elementary or the reticulate?
Elementary.
Yes, it will be containing the elementary. So with that elementary form, it will get access into the host. So it will enter the hive. Then when they get to the hive, they find, some cells there, they enter the cells, they start replicating as reticulate body. So with time, they can get into the other body tissue, they can find their way to the bloodstream, then, to the other part they want to find their way to. But they keep replicating as the reticulate body. So with time, the reticulate body, after replicating, it will now start reorganizing all those replicated cells into the elementary body. So the elementary body now ruptures from the cell and finds its way outside. So, for example, maybe someone has chlamydia trachomatis infection of the urethra. The person has a urethritis. So, once there is the replication from the reticulate body into the elementary body, so during sexual intercourse, the elementary body can move, through the semen and get deposited into the vagina of the female. And the elementary body can colonize the epithelial cells of the vagina and enter into that person. So once it gets into the person, it starts replicating again as reticulate body. Then the cycle continues like that. So just have it in mind that reticulate is replicative one. Elementary is the entry format and it is metabolically inactive. So we've talked about what it causes. Another peculiarity is that it has a cell wall, but it lacks the classic peptidoglycan because N-acetylmuramic acid is important in the formation of the peptidoglycan. So it has reduced level of the muramic acid, so the peptidoglycan cell wall is not well developed. It's not well developed. So that's that about chlamydia. Um, Organisms generally, both the pneumonia, the chlamydophila psittaci, as well as the trachomati, all the chlamydia. So beta lactam is not actually active, on chlamydia because they don't have the classic peptidoglycan cell wall where you can inhibit the synthesis of that cell wall. So they don't even have it. So it's not going to act on it at all. So we've talked about psittaci being present within the avian reservoir like the parrot, causing atypical pneumonia. And the way you can diagnose chlamydia, although this is not very high yield, but if you want to know it, it's fine. So it's been this PCR has replaced culture. So before they used to try to culture chlamydia, but now they just do the nucleic acid amplification test. Just try to get segment of the nucleic acid and you try to replicate them and amplify them rather and see if it um if it looking at that of chlamydia, so you can make your diagnosis. Sometimes we take out the inclusion body. So the inclusions are these reticulate bodies. So you take them, then you take maybe a swab of maybe the urethra or something, then containing the reticulate body, then you stain it using your Giemsa stain. So if you can see the reticulate bodies there, okay, you can make your diagnosis. Sometimes you can use fluorescent antibody smear. So antibody against this chlamydia, you just bind it with the chlamydia antigen, then if there's an interaction, you can see fluorescence, then you can make your diagnosis. Those ones are not high yield, so it's not something that they commonly test. So we should just know the way they present, what they cause, and the organism that caused them, as well as the strain. So we are going to talk about the serovar that causes some of those infections later now as we are moving down. So what's the treatment for chlamydia? So we said it that majority of those atypical guys, you want to treat them with doxycycline. So doxycycline is one of them. You can use a macrolide like azithromycin, especially for people that are pregnant because you don't want to give them doxy. So give them azithromycin, it will help them. Then you guys remember that for the sake of PID, we said that, or urethritis. So we said that for PID particularly, the two common organisms is your chlamydia and your Neisseria. So if you have not ruled out both of them, you have to give mixture of ceftriaxone and doxy. So if you have made diagnosis of Neisseria, but you have not ruled out chlamydia, if you are giving ceftriaxone, IM ceftriaxone 1 dose for your Neisseria, you must combine it with your doxy for chlamydia. Same thing for chlamydia. If you have diagnosed chlamydia and you have not ruled out gonorrhea, and the person is having a PID, you must give doxy for your chlamydia and introduce ceftriaxone with it to treat any possible concomitant gonorrhea. So what are the serotypes? We have serotypes A to L. A to L. So the ABC, those are the ones that are responsible for causing the trachoma or the follicular conjunctivitis. So it's a very chronic infection that will lead to formation of cells that look like granuloma. So you're going to see particles of, lesions that look like granuloma because it's chronic irritation of that conjunctiva that bring about the formation of those follicle-like lesions. So it's the serotype ABC that causes follicular conjunctivitis or trachoma. So, and the organism we are looking at is Chlamydia trachomatis, not Chlamydophila pneumonia or Chlamydophila acetachi. Chlamydia trachomatis, the serotype A, B, and C. Those are the ones that are causing the follicular conjunctivitis or trachoma, which is one of the commonest causes of blindness in developing countries. So, after the C, we are left with D. So, we are stopping at K. So, the way to just spam this is that D to K are the ones that are causing the neonatal problems as well as the genitourinary problems. The neonatal problems as well as the genitourinary problems. So what are the neonatal problems that chlamydia trachomatis can cause? Chlamydia trachomatis can cause neonatal pneumonia and it can cause neonatal conjunctivitis. So I think I've seen a question before that we're trying to paint that conjunctivitis, that the person developed that conjunctivitis just few days after birth. That's a neonatal ophthanatorium or ophthalmia neonatorium rather ophthalmia neonatorium. So few days after delivery, there's exposure, to the chlamydia within the genital tract of the mother. So the neonate picks it up from there and the person can develop the neonatal conjunctivitis. Then they said afterwards the infant started coughing and this cough is characteristic, we call it staccato cough. So staccato cough is just like a cough that has honking intonation, maybe like somebody's owning. So that's that me I cannot demonstrate that cough, but they said it has that tone, and the baby coughs, takes a deep breath, like inspires rather. So inspires, then coughs again. So I think that's the reason why the cough has that honking or backy tone. So staccato cough. So once you are saying cough, symptoms of pneumonia alongside with conjunctivitis, you are tilting your mind towards chlamydia trachomatis. And another clincher for that pneumonia is that it is associated with eosinophilia. So they are going to put in the question that the eosinophil count is increased. Eosinophil count is increased. So once you are seeing a neonate with conjunctivitis, with pneumonia-like symptoms and elevated eosinophil counts. So not even neutrophils like you expect for a bacterial infection, but eosinophils. Your diagnosis is neonatal, pneumonia with neonatal conjunctivitis from a chlamydia trachomatis infection. What serotype? D to K. D to K. Any one of them from your D to K can cause um, this problem. So the two neonatal problems we are looking at: neonatal pneumonia and neonatal conjunctivitis. Then the genitourinary problems like PID and urethritis. So all the other things can be consequence of the PID. Ectopic pregnancy is a consequence of the PID because you have additions and all those things, making the lumen of the fallopian tube not patent, so you can have implantation of the ovum at that point, leading to ectopic pregnancy. So it can cause infertility, it can cause other things. So those ones are actually caused by the D2K serotype. So the L1, so after K, we are moving to L. So and that's where we are stopping. So for the L1, we have L1. For the L type, we have L1, L2, L3. So that is the one that is responsible for causing lymphogranuloma venereum. And we have talked about this the last time we are looking at questions. So we said the clincher for lymphogranuloma venereum is that it's one of the painless cause of ulcers. So the ulcer for lymphogranuloma venereum is painless, but it's associated with lymphadenopathy. So there's inflammation or enlargement of the inguinal lymph nodes just near the genitals. They can ulcerate, forming bulbs, and it is painful. It is painful. So what you use to treat your lymphogranuloma venereum is doxycycline. Doxycycline. So what we use to treat the neonatal conjunctivitis is erythromycin ointment usually. So you know your arthritis, your PID, give your doxy. It will take care of it as well. So if the person is pregnant, you can use um macrolide, maybe preferably azithromycin. So do we get everything about chlamydia trachomatis now?
Yeah. Yeah.
Okay. So the next organism, Gardnerella vaginalis. Um, vaginal this Gardnerella vaginalis organism is a pleomorphic gram-negative rod. So sorry, gram variable rod. So it can be gram positive, it can be gram negative. Yeah. So it's a pleomorphic gram variable rod, which is involved in causing bacterial vaginosis. We should always remember this. One thing about this bacterial vaginosis is that one of the implicating organisms is just this Gardnerella vaginalis. It's not the only one that is doing it. So it's more like an interplay of all the anaerobic organisms in the vagina, but particularly your Gardnerella vaginalis. So what causes this bacterial vaginosis? Anything that can lead to disruption of the normal flora, normal bacterial environment of the vagina can lead to bacterial vaginosis. So if somebody is having too much sexual activity and you are killing some bacteria within the vaginal community, particularly lactobacilli, lactobacilli, the person can be predisposed to bacterial vaginosis. So in that setting, all those other anaerobes, including um, Gardnerella vaginalis, start proliferating and they can cause the infection. So the major pathology there is that there is reduction in the load of the lactobacilli. So lactobacilli is one of those acid-producing organisms in the vagina. So if somebody has exposure to um, too much sexual intercourse, use of antibiotics, douching, vaginal irrigation, all those things can kill off the lactobacilli and they can allow your Gardnerella vaginalis as well as the other anaerobe to overgrow. They can colonize that vagina, take over the whole place and cause the infection. So how do they present? They present with gray white discharge. Very important. Gray white vaginal discharge that is fishy, that has a fishy smell. Gray white vaginal discharge with a fishy smell. You are on your way to making diagnosis of bacterial vaginosis. What happens to the pH of the vagina in these guys? So because of the fact that the lactobacilli level is reduced, lactobacilli helps us to produce acid. So that means that you are and the normal vaginal pH is around maybe 3.8 to 4.5 or so. So it's kind of acidic because of this lactobacilli that is there. So we've killed off all the lactobacilli. So that means that it will be more than 4.5. To be more than 5.5 because it will no longer be acidic as it used to be. So that's another thing to look out for. So the vaginal pH is going to be more than 4.5. They are going to have a gray white vaginal discharge, which is not painful. It doesn't itch and it is not painful, unlike the other cause of vulvovaginitis like trichomoniasis or candidiasis. Those ones are going to be painful. And we must pay attention to the fact that it is not sexually transmitted. So if you are saying something is sexually transmitted, that means that that organism gets inoculated into the reproductive tract during sexual intercourse. No, It's just that sexual activity can help disturb the bacterial load, within the vagina, killing off the lactobacilli and making the person, susceptible to developing this organism. Doesn't mean that it is sexually transmitted. It is not sexually transmitted. So when you do a wet mount, so you take, a swab of that area, then you do wet mount of it on a microscope. So what do you see? You see your cleave cells. So cleave cells contains vaginal epithelial cells that are containing or covered with gardnerella. So your gardnerella, has colonized the whole vaginal area. So they are within the epithelial cells. So if you obtain a swab and you do a wet mount of that, you can see your cleave cells, which are vaginal epithelial cells that are filled with the gardnerella infection. So they have this stippled appearance. So you can see the way they look like. So once we see this kind of image, you know, this kind of image on wet mount, you know that this is bacterial vaginosis we are dealing with. If you do a wet mount of a swab from someone that you are suspecting to have trichomoniasis, you are not going to see cleave cells. What you are going to see is multi-flagellated trichomonads. So you are going to see the trophozoites of trichomonads. They'll be moving. You know, you are not going to see cleave cells. Yeah. So that is that. So if you do, mount for candidiasis, you are going to be seeing pseudo hyphae. So if that pseudo hyphae is peculiar to candida. Anytime you hear pseudo hyphae anywhere, guys, pseudo hyphae, you are thinking of chlamydia. Yeah, candida. That is candida. Pseudo hyphae, yeast with pseudo hyphae, candida is your answer. Multi trophozoites, trichomoniasis. Vaginal
Doctor,
epithelial cells containing Gardnerella cleave cells. That's your bacterial vaginosis. Dr. Bisola, you are saying something.
you. There's one that has the description of jam tube with constriction.
Yeah. So down tube with constriction is still your candida.
Okay.
Yeah. So
Doc-
candida can be
Giant what?
yeah, it's not giant tube, it's jam tube. So I think she made a mistake too. When we get
I
to
said
candida, hello?
I said jam tube. Oh.
Okay. I thought we heard someone was saying giant tube. So your the because the thing is when we get to fungi we are going to talk about them very well. Some of them can be dimorphic. You can have them existing as a mold, you can have them existing as a yeast. So mold is the one that contains that hyphae. So anything that contains hyphae, those hyphae are filamentous. So when they contain the hyphae and they have filament, we call them mold form. So if they don't have the filament, they don't have the hyphae, we call them yeast. So um the germ tube is actually like a mold form of candida. So because the germ tube contains hyphae that is normal, that is not having constriction, it is just a plain parallel tube. Don't worry guys, when we get there we are going to talk about it and it's going to be clear. Let's just focus with what we have here. So we've talked about the organism implicated. We said Gardnerella vaginalis is the organism. But the pathology is that there is a reduction in the level of lactobacilli. That is why your Gardnerella vaginalis can proliferate and cause the infection. How will they present? They are going to have non-painful, non-itchy, gray-white vaginal discharge. Gray-white vaginal discharge. If you try to analyze the vaginal pH, it's going to more than 4.5 because you have taken out the acid-producing bacteria, which is lactobacilli. It's going to be more than 4.5. If we do a wet mount of the swab that we are obtaining, it's going to show us cleave cells, which are vaginal epithelial cells covered with the gardnerella. These are the cells. There's something we call the whiff test. So I mean whiff test. So once you take a portion of the discharge from the vagina and you mix it with 10% KOH, it's going to give a fishy odor, just like the normal smell of the vaginal discharge. It's going to have this fishy odor. So your bacterial vaginosis is highly specific for that. Once you have a positive amine whiff test. So, so do you guys remember the Amstel criteria? Hello?
Not really.
Okay, yeah. So Amstel criteria is what we have said. we have said Amstel criteria. So having
Few cells,
mhm,
reduce pH,
reduced pH,
um,
positive wave test, positive wave test,
positive.
then the gray white vaginal discharge. Those are our Amstel criteria. You just need 3/4 of that to make diagnosis of bacterial vaginosis. So what do you do once you see someone
Sorry, what did you call it? You said it was Amstel criteria.
Amstel, yeah, Amstel criteria.
Thank you.
Yeah,
Can you
so
repeat all those things that you just listed in it now?
yeah, so
Sorry.
how would they present? Gray white vaginal discharge with a thick smell. That's one. If you do analysis of the vaginal pH, it's going to be more than 4.5. That's two. If you do a wet mount of the discharge, it's going to have the clew cells, vaginal epithelial cells covered with gardnerella. That's three. Then if you do your whiff test, which is mixing the discharge with 10% KOH, you are going to obtain fishy odor. That is the four. That's the fourth one. So 3/4 of that is what you need to make diagnosis of bacterial vaginosis. Do you get that okay,
Okay.
Cecilia? Yeah. So
Yeah.
what's the treatment? What's the treatment? Metro or clindamycin? Metro or clindamycin? Most of the time, metro. Metro. This metro is common to many of them. You give metro to for trichomonas. So you should always remember metro first. Metro. So metronidazole for your gardnerella, metronidazole for our trichomonas. So you can also use clindamycin for it. Okay, so let's go to the zoonotic bacteria. These are bacteria that causes I don't know if we are going to talk about trichomonas and candida later. Or we should just talk about them here. I think there's still a part down that we are going to talk about it.
I think they put trachoma as part of the protozoa or something.
Yeah, it's under the protozoa. Yeah, we are going to talk about it there. But we've talked about it. I mentioned that one thing that you want to look out for with respect to trichomonas is what? A green,
Multi-flagellated.
yeah, so multi-flagellated trophocyte, yeah, that's one. Then they will
So
have a
I
greenish discharge.
Greenish discharge.
Exactly. They have a green discharge. And in some people, you can see the punctate hemorrhage within the cervix. So
Yeah, the
strawberry,
cervix. Yes, you said that. Strawberry cervix.
strawberry cervix.
Yes.
And the vulvovaginitis in them is very painful. It's itchy. They're always scratching everywhere and it's painful to them. So that is it. Candida, the discharge is going to be cordy, thick. We call it the cheese cottage. If you look at it, you are going to be seeing like whitish discharge that is going to adhere to the walls like that. So cheese, cottage, very, very thick discharge. It's very itchy too. Candida is very itchy. And the pH is only in Candida that the pH is normal. So in Candida, the pH is less than 4.5, normal acidic pH. But in Trichomonasis and bacterial vaginosis, the pH is more than 4.5 in there. So in Candida, if you do the vaginal pH, it is less than 4.5. It is normal in Candida. They have this cordy white discharge. In Candida, it is itchy. And if you do the amount, you are going to see yeast with pseudohyphae. Yeast with pseudohyphae. So the yeast form of Candida is the one that contains the pseudohyphae. The mold form of Candida is one that contains the germ2. Yeah, so we are going to get there and we are going to talk about it. So I think we have differentiated and compared and contrasted the three of them. So that's no matter how they paint that history, you'll be able to figure out the answer. So zoonotic bacteria are just infectious diseases that you can transmit between the animals and humans. So you can transmit between animals and humans. We are just going to focus more on the ones that are high yield because you can know everything actually, but I don't think it's necessary to just be stressed. So anaplasma, I think we've talked about anaplasma before. Can anybody remember anything about anaplasma?
Study stick.
Fantastic. So the study stick. So what did we say a study tick can transmit?
It can transmit anaplasma. It can transmit Lyme's disease. Um, and then one more thing, babesia.
Babiosis.
Yeah.
Babesia.
So the code is my name, BAB. BAB.
Babs.
Babs. Yeah, that's
Babs. So
true.
the B for the Borrelia
Lyme.
burgdorferi for Lyme. The A is the anaplasma. Anaplasma is a bacteria. Anaplasma is a bacteria. So the last B is a babesia, is a protozoa. So B, protozoa. Yeah. So the three of them can be transmitted to the exodistic anaplasmosis. So I don't think they are going to ask us anaplasmosis, but the clincher for anaplasmosis, I'm going to mention it again later, but let me just say it here, is that once you just look at the um the investigation, and they are saying they are they are um they are seeing presence of a morule within granulocytes. So morule within granulocytes. So morule are just like inclusion form of this anaplasma. So they form morule, and that morule attacks the white blood cell. But what white blood cell do they attack? Granulocytes. So once you see a white blood cell that is having like granules, the nucleus is not appearing completely circular. It just appears, can you guys look at the nucleus of neutrophils? Do you remember the way it looks like? You know that it's not circular.
Mm-hmm.
Yeah,
The
use
blood cell.
neutrophils.
Neutrophils, yeah.
Mm-hmm.
Okay,
You
yeah.
know that it will be like 3 or 4. You guys remember
Yeah.
their shape. So if it is eosinophils, it's going to be true. I hope you
True.
guys can
Yeah.
remember. Bilobed.
Yeah.
Mhm.
Yes, yes, and the lymphocyte is one.
Yeah, that lymphocyte, that one will be entirely circular. So you know that this is your
Circular,
lymphocyte.
yes.
This one is either
Yeah.
lymphocyte or monocyte or all those guys. Those ones have distinct shape.
Yeah.
But your granulocytes are kind of distinct. Those ones are kind of curved. They are curved.
And then they are multi, like they are more than two.
Yeah,
They are
so
polymorphonuclear, yeah.
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 So your eosinophils is 2. Your neutrophils can be like more than 3 or 4. Yeah.
Up
Yeah.
to 6.
Yeah, up to 6. Fantastic, Dr. Yeah. Yeah. So yeah, and fantastic point from Dr. Toby. Polymorphonuclear leukocyte. Yeah, so Bartonella species is another one. Okay, yeah, so that's that about anaplasmosis. They will tell you morula within granulocyte. Please, guys, morula within granulocyte. That is anaplasma. We are going to see the picture. One thing about this anaplasmosis, guys, is that it likes attacking, the blood cells. So it attacks the red blood cell, the white blood cell, platelets. So it causes thrombocytopenia, which can lead to bleeding. So they can have this rash, this petechial rash. It attacks the red blood cell, causing hemolysis. So they can be jaundiced. They can be jaundiced, and they can be anemic. It attacks the white blood cell and is going to cause, leukopenia. That's why, we've already said that they colonize the white blood cell, so they can destroy the white blood cell and cause, leukopenia. So that's that about your anaplasmosis. Yeah. So Bartonella species, another one. We've seen a question on this before. Two things that it can cause: catch scratch disease and bacillary angiomatosis. So catch scratch disease is just like someone that has exposure to an animal, maybe a dog or a cat, but most commonly cat. So the cat has a scratch, made a scratch on the person's skin. They can inoculate this Bartonella species, particularly Bartonella encelli. It is Bartonella encelli that causes cat scratch majorly. So that Bartonella gets into the skin, then it can cause erythema of that area. It can cause lesion. It can cause even lymphadenopathy of the nearby draining lymph node. So you will see redness. You can see ulceration of that area. Then you can even see regional lymphadenopathy very close to that area of inoculation. Catch scratch disease. The question will have said it that there's a scratch mark. You already know what they are talking about. So the way the question asked, for the last, I think it was linked to bacillary angiomatosis, where they were like, somebody had a scratch from a cat, from some pet that the owner was keeping, and they were like, what is a similar condition that can arise from the organism implicated in that condition? So our answer will be bacillary angiomatosis. So, and we said it
Mm-hmm.
earlier that bacillary angiomatosis is a vascular skin lesion. So you just have abnormal proliferation of blood cells within the skin that leads to formation of purplish or reddish papules or plaques. Most of the time is papules, and how they have close resemblance with Kaposi. So when we're dealing with these guys then in dermatology, one question I used to ask them was that how do you differentiate bacillary angiomatosis from Kaposi. I used to ask this question a lot, and I've asked Dr. Toby like more than 3 times. I'm sure of that. But I know that it's been a long time that I've done it. So there's tendency that I will have forgotten. So there's
I
tendency
know
that
that Kaposi is violacious and
yes, it's populish, yes.
publish, yeah, and
It's actually with HIV. So someone that has HIV
yeah,
or woman that
HIV.
is virus AIDS
It's
is yeah. So but the difference is that once you do a biopsy, you might not be able to separate them visually. So once you do a biopsy, you are going to see neutrophilic infiltrate for bacillary angiomatosis. Why for Kaposi, we are going to see
That makes
lymphocytic
sense.
infiltrate. So so that is one of
Okay, that makes sense. That makes
that was one of
sense.
the separating factor. Please don't
The
forget that.
viral infection.
Exactly. It's a
HIV is a
bacterial
viral
infection. In fact,
infection.
you're absolutely
Kaposi is secondary to all the viruses, so it makes sense for it to be the lymphocytes. Thanks.
lymphocytic.
yeah. So Borrelia burgdorferi Lyme disease, we are already familiar with this. Borrelia recurrentis, well, we might decide to learn this. It causes relapsing fever. So you just have this recurrent fever, headaches, myalgia, joint pain, muscle pain, you know, from Borrelia recurrentis. So this is a Borrelia guy, one of those spirochetes, that we said that we can visualize with GIMSA, unlike the other ones, our Leptospira and Treponema that we cannot see. But we can see Borrelia. We can see Borrelia, and it can cause two things because there are two species, Burgidoferi and Recurrenti. So Recurrenti causes relapsing fever. Just see that the fever comes, keeps coming and going, relapsing. So fever, joint pain, muscle pain, headaches, and implicating um vector is the louse. So louse is what is transmitting it. The louse is the what is carrying that Borrelia recurrent. It's not very high yield, but I just want to mention that once we see louse, we are thinking of some things, especially Rickettsia prowazekii, louse, Rickettsia prowazekii, Borrelia recurrentis, louse. Yeah, so Brucella, we know Brucella very well. We know Brucella very, very well. So this is brucellosis or undulant fever that can also cause what else? After the undulant fever, what follows? That code that we used to learn it.
Sweating.
Sweating.
Mm.
Nice one, Dr. Zuriat. So sweating. So after the sweating, what's the third one? We talked about two other things. So someone having undulant fever, sweating,
Will
then
there be chills?
no. It's not actually related to them. So that is the arthralgia or the myalgia that they present with.
Malaria.
So undulant fever that's here with trenching night sweat with arthralgia, that is likely to be brucellosis. We said brucellosis is what? It causes non-sedating granuloma, right? Non-sedating granuloma, and it's one of those things that you can get from unpasteurized milk. Unpasteurized milk,
Mm.
brucellosis. Unpasteurized milk, listeria. Unpasteurized milk, campylobacter. We should not forget.
Is it the one with lymphocytosis?
No. So which one is the one with lymphocytosis? I
Mm.
so which one is the one with
Is it
lymphocytosis?
Borderline,
Borderella?
I think.
No. That is pertussis. That is pertussis.
Okay,
Pertussis.
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 What's the question? Sorry, what's the
Okay,
question?
yeah, whooping cough, whooping cough. Okay.
She said
What's the
which of the
question?
following bacterial infection is associated with lymphocytosis?
Oh, okay.
That is
Pertussis.
pertussis. Hmm?
So
Hello?
yeah, continue.
Yeah. So we said I was trying to give you guys a code that you can use to remember it. We said that pertussis is the one that inhibits the activity of the phagocyte. Abi now. So your neutrophils and your macrophages are not responding.
Will not be able to respond.
Response.
Yes, you said
Yeah.
it. You
Yeah,
said
yeah.
it.
So
Just
the
remember
only
that.
thing that will come to the surface will be the lymphocytes. Okay, okay.
Yeah.
Yeah. So and you remember the toxin of it uses the tracheal toxin and the pertussis
And the
toxin.
pertussis toxin. Yeah.
All right. So you can get it. You can get this brucella from inhaling, infected, maybe done droppings from the animal or tissue fluid and something from the animal like that. But unpasteurized milk is very important. Campylobacter too, animal, very important because we saw a question and it causes bloody diarrhea, particularly in which age group? Campylobacter, which age group?
In children, 2
In children.
years.
In children.
Children, yeah.
In children. Bloody diarrhea, Campylobacter jejuni is one of those things you want to consider. You see bloody diarrhea, you're thinking about Salmonella, you are thinking about Shigella, you are thinking about Campylobacter, you are thinking about enterohemorrhagic, you are thinking about enteroinvasive, you are thinking about which one again? Okay, I think we have mentioned almost the basic ones that causes bloody diarrhea. Shigella, Salmonella, enteroinvasive, enterohemorrhagic, Campylobacter, bloody diarrhea. So you can get them from unpasteurized milk, contaminated food, and also infected animals. These infected animals is very important. Feces from infected animals, very, very important for Campylobacter jejuni. Campylophilia psittacosis, so that is an atypical pneumonia that you get from parrot. Coxiella bonnetti, Q fever. So Q fever is also one of those guys that is related to the rickettsia. So Q fever likes affecting the lungs, likes affecting the heart, and likes affecting the liver. Those three guys, the heart, the lungs, and the liver. So the way to palm it is that Coxiella bonnetti causes Q fever. How do we get this Q fever? Usually through inhalation of the aerosols from the sheep or cattle, droppings, urine, or amniotic fluid. So it's an airway thing. So that means that if something is an airway thing, that means it will find its way to the lungs. It can cause a pneumonia. So if you guys remember, although I'm not sure we emphasized it, when we're talking about the atypical pneumonia in respiratory, we listed some organisms: chlamydia, pneumophilia,
Legionella.
legionella,
Mycoplasma.
mycoplasma. You get. This guy is also one of them. Aside the viruses, the RSV and all those things, adeno. Coxiella bonnetti is also one of them. It can cause an atypical pneumonia. So they have this low-grade cough, fever, dyspnea, and all those things. So it can affect the lungs, can cause an atypical pneumonia, and it can cause culture negative. What? Who wants to help me complete it? Culture negative. Once you hear culture negative, what comes to your mind? We have actually
Coxiella and Legionella.
No, that's not what I'm saying. Okay, I think yeah. So that what I'm thinking of might not actually work because you have so many things that the culture negative. Yeah. So but what I'm saying,
Infective endocarditis.
infective endocarditis. Thank you, Dr. Zulia. Infective endocarditis. So culture negative, infective endocarditis. You are thinking of Coxiella bonnetti. You do your culture, you do not grow anything. You are thinking of Bartonella and Selly for endocarditis. So Coxiella and Bartonella are two major organisms that you want to consider, with respect to culture negative gram state. So that's Q fever for you. Pneumonia, Coxiella can also cause culture negative endocarditis. It can cause granuloma formation, like inflammatory reaction within the liver that can lead to right caudal abdominal pain, can cause jaundice, and the other symptoms of liver pathology. So don't forget the lungs, the heart, and the liver for Coxiella. Then we have Elytra chafensis causing ehrlichiosis. So this guy is also being paired with anaplasma. So they pair Elytra with anaplasma. So anaplasmosis, ehrlichiosis. Both of them are bacterial infection. Both of them are transmitted by ticks, but the ticks are different. So the ticks for anaplasmosis is exotic tick. The tick for ehrlichiosis is what? Amblyoma, low stachic. You might not palm this one, it's not very high yield. But the clincher for this one is that by the time you are doing your blood work, you are going to notice morula in what? In monocyte. So what is a morula in something that we say for anaplasmosis?
Granulocytes.
A
Morula and
Nice.
granulocytes.
Exactly. So for Elytra,
Immunocyte is which one? Okay.
Elytra.
It's elytra.
We are going to be
Monocyte.
monocyte in morula a monocyte. That is your ehrlichiosis. Ehrlichiosis. Yeah. So yeah, that is that about Ehrlichia. I don't want to talk about the symptoms. It's just normal symptoms that they have, normal constitutive symptoms. But sometimes they can get to the CNS, they can get to the respiratory tract and be causing respiratory failure and the other things. But I feel the investigation can help us, nail whatever we are looking at. So once we look at the specimen, we are seeing monocyte contain the morula ehrlichiosis. So tularemia, yeah. So tularemia can be transmitted by rabbit. They can have normal nausea, vomiting, headache, and all those things with tularemia. It's not very high yield. Leptospira is something we should pay attention to. We've talked about it. Leptospirosis, you can get it from rat, urinating inside the water. So any water that is contaminated with rat urine, they can develop leptospirosis. People that use water a lot, people that are soft,
Many people.
yeah,
Mm.
leptospirosis. So they can have fever, they
Or
can have,
or farmers.
or farmers, yeah, tropical rainforest, people that farm in tropical rainforest, so they can be exposed to leptospirosis. So they can have fever, they can have jaundice, they can have calf pain, they can have calf pain. And we talked about the Wills disease. The Wills disease, which is not leptospirosis, which is more like an advanced form of leptospirosis that is now taking both the liver and the kidneys and the blood vessels. So they have hemorrhage causing anemia.
But
They have AKI from the affectation of the kidney. There's elevation of the creatinine value, and there is jaundice that is very severe due to affectation of the liver. That is Will disease, and that is one of those presentations from Leptospira organism. We've talked about Mycobacterium leprae. So that one you can get it from animals too. Armadillo, because armadillo is the largest reservoir for leprae in the US. So although we said that somebody can get leprosy from contact with another person that has infection. Maybe the person that has the leprosy just sneezes, because you can see it within the airway secretion, aerosol droplet, maybe from the mouth or from the nose. Once the person takes it in, they can develop the leprosy. So because of the fact that they can be gotten from exposure to armadillo, it's classified as one as those zoonotic disease. So another one is Pastorella multocida. So this one too is high yield. But whenever you see Pastorella, what should come to your mind is animal bite, especially from dogs. Pastorella, dogs. Me, I have programmed that stuff in my head like that. But when I see Pastorella, I'm looking for dog bite, because
bites.
most of the times you'll be correct. So that site where you have the bite, the person is going to develop cellulitis from there, and it can spread from the subcutaneous tissue to the bone, causing osteomyelitis. So that's the presentation. You have cellulitis, redness, pain, swelling, tenderness within that area following bite from a dog, and there is osteomyelitis subsequently. Pastorella multisoda. That is what you are looking for. So you can just pick the next thing is that they might not put Pastorella there. You already know your gram stain feature of Pastorella. So how will they appear? Anybody? Pastorella. Just like we have said.
Is it with the LS?
Yeah, so it's with the LR. So how is it going to be?
That will be black in charcoal or something like that.
No, I'm talking about gram stain.
Gram
Oh,
negative
Gramston.
Coccobacilli.
Yes, that is all. No catch. No catch at all. A gram negative cocoa bacilli. That's what you are going to pick in the option. A gram negative cocoa bacilli. Some people will still be confused that omo they no put and we know, and I know that it's Pastorella. I did not see Pastorella there. You have picked your option, you have moved. Gram negative cocoa bacilli is an HeLa, so cocoa bacilli. That's what you are going to see. Rickettsia prowazekii. So I've said it, the louse. The louse. So prowazekii is a louse guy. Another one for the louse is what? Our Borrelia recurrentis. Louse. Louse. So prowazekii causes epidemic typhus. We are going to get there. You guys might not get it now. By the time we are talking about the Rickettsia fully, we are going to talk about it. So we have three major species for the Rickettsia, and they cause two different disease. So we have the Rocky Mountain spotted fever, and we have the typhus. Rocky Mountain spotted fever the triad for this guy is fever, headache, and a rash. Fever, headache, and a rash. If somebody has fever, headache, and a rash, the next thing is you want to look at the characteristics of that rash to know if you're actually dealing with Rickettsia rickettii. So the way I palmed it is Rickettsia rickettii causes rocky, that's the R, Rickettsia, rickettii, R, Rocky Mountain Spotted Fever. So it's been translated by the demarcantor dog tick. So this one is tick. Yeah. So dog tick demarcantor. How will it present? They have a fever, they have headache, and they have a rash. How will the rash present? The rash is going to be centrifugal. So the rash is going to start from the ankle. So the ankle is the distal part of your distal extremity, and it's going to start from the wrist, which is the distal part of the upper extremity, and they are going to move inward. So that's centripetal rather, not centrifugal. I'm sorry, centripetal, because they are moving from the extremity inward to the trunk. So they will get to the trunk. Now, when they get to the trunk, they're also going to spread, from the wrist, it will get to the palm, from the ankle, it will get to the sole. So you guys remember that we talked about some 3 disease conditions that can affect the palm and the sole in terms of the rash. The rash affecting the palm and the sole. So aside Rickettsia rickettii, which other one do you remember?
Coxsackie A and syphilis.
Coxsackie
A?
and this thing,
A?
typhoid.
No.
Syphilis. Syphilis.
Syphilis.
Syphilis.
What form of
Syphilis.
syphilis? You have to say it too.
It will be the tertiary.
It's
No.
secondary.
The secondary syphilis.
That's the systemic.
Yeah, we said tertiary syphilis is your gommas, CNS, and CVS. That's tertiary. Secondary is a rash, lymphadenopathy. So they have skin, mucous, membrane affectation, and lymphadenopathy. Those are the 3 things in secondary. So we are seeing a skin lesion, maybe a rash, that's affecting the palm and the sole. Or you are seeing condylomata lata within the genitals. That's secondary. There is affectation of both the skin as well as the mucosa. Then the third part is the lymphadenopathy. So you have a general lymphadenopathy in secondary. Primary syphilis is only the chancre, painless, clean, well circumscribed, shallow ulcer. Primary syphilis. Tertiary syphilis is the gomma, the CNS, and the CVS problem. So you can have syphilitic aortitis, aortic aneurysm, tabes dorsalis, Charcot joint, all those things. Agilobacter pupil, what you are talking about, your tertiary syphilis. Then that's all about Rickettsia rickettii, Rocky Mountain Spotted Fever from dog tick. Rickettsia prowazekii. So this one is the epidemic typhus. So we've talked about the Rocky Mountain Spotted Fever. The second one are the typhus. So we have 2 types of typhus: the epidemic typhus and the endemic typhus. So which one causes the epidemic typhus? The one that has P, which is the prowazekii. And we said it that whenever we see prowazekii, we are thinking of the louse, the body louse, So epidemic, prowazekii, body louse. The nature of this rash is different from that of the Rocky Mountain Spotted Fever from Rickettsia rickettii. Yeah. The last one is the endemic typhus. So that one is the Rickettsia typhi. That's the last one. That one is transmitted by fleas. So we are looking at 3 things: fleas, tick, and louse. Fleas, tick, and louse. So which one is the louse? The epidemic, prowazekii. Which one is the tick? Demarcantor. That is the Rickettsia rickettii that causes the Rocky Mountain Spotted Fever. The endemic one is the Rickettsia typhi, which is transmitted by the fleas. With time, we are going to get used to them. Then we already know the salmonella. Yersinia pestis can cause plague. So the way plague is also transmitted by fleas. So fleas also transmit plague. And the common way they ask question about this plague is to just describe bogo. So just describe lymphadenopathy somewhere. So the person can get exposed to rats, When the person gets exposed to rats, they develop swelling within the lymph node. So they have this bubonic plague. So that's where you have inflammation of the lymph node. They can also have pulmonic plague. So they can have this pneumonia that is kind of atypical, and they can have septicemic plague. So dissemination to the blood, causing DIC, hypotension, gangrene of the toes. So those are three forms of the plague. Bubonic is the commonest one that they usually ask. Inflammation of the lymph node, swelling of the lymph node that is very painful, bubonic plague. Following exposure to rats, you know that is plague they are talking about. So the rat is a vector. So the fleas is what carries this, the rat rather are the reservoir, the flea is the vector that carries the organism, which is the Yersinia pestis, causing the plague. Okay, so now when I'm going to talk about this rickettsia now, it will be as if I'm revising because I've tried to talk about them initially. So, Rocky Mountain spotted fever, the rickettsia, what do they cause? They can cause two things. Rickettsia can cause Rocky Mountain spotted fever, they can cause typhus. Rocky Mountain spotted fever, the R, that's the rickettsia rickettii, the R. The vector is the dermacanthor tick. How does the rash start? It starts at the wrist and the ankles. I've talked about it. This starts out of the extremities, the wrist and the ankles, then they spread to the trunks, the palm and the soles. What is the classic triad? Headache, fever, and the rash. So, the other infection that can affect the hand, that is the sole and the palm, includes Coxsackie and our secondary syphilis. The typhus, two types, endemic and epidemic. So they are separating them because the nature of the rash differs. So the typhus have, common presentation. It's just the organism that's causing them that varies. So if you are looking at endemic typhus, that is the Rickettsia typhi, transmitted by the fleas. When we are looking at epidemic typhus, that's the Rickettsia prowazekii, transmitted by the human body louse. So how did they start? They will start from the trunk and they will spread out to the extremities. So that is a centrifugal spread. Fugal is outward, spital is inward. So the typhus will move from the trunk outwards to the extremities. And when they get to the extremities, they don't affect the palms, they don't affect the sole. So those are the typhus. Do we get it now? Dr. Francois, did you understand that?
Yeah, I did. I did. Yeah.
Dr. Abisola, did you pay attention to that?
Yes, sir.
Okay, man. So that's that about the main rickettsia. Those ones have rash that is common. What do you want to give them? Dogsy. They are atypical organisms. You can see Dogsy is also working for them. Dogsy. So the ones that are very similar to the rickettsia, but they have they don't commonly present with rash. Those are the ehrlichiosis, the anaplasmosis, and the Q fever. So we are just picking some of those what's it called? Some of those zoonotic infection, and we are trying to dilate on them. That's what they are trying to do. They now classify them into the ones that are rash predominant and the ones that rash is very rare in them. So ehrlichiosis, anaplasmosis, Q fever, they don't typically present with rash. So we've talked about Ehrlichia already. The vector is also tick. Can we remember the tick? I know that we might not be able to remember, but do you have anybody that remembers the tick for Ehrlichia?
Ehrlichia is not exotic, it's Lone Star.
Yeah, so that is Lone Star. That's the amblyoma. That's the amblyoma. Yeah. So that's what we see. The monocyte within morule. So morule within monocyte rather. Morule within the monocyte. So we call them mulberry-like inclusion. So those morule looks like mulberry-like inclusion in them within the cytoplasm of the monocyte. So this is what they look like. So can you guys see this?
Yes.
So you cannot call this a granulocyte. Can we call this a granulocyte? No. So but we
No.
can but we
The
can
neutrophils one.
but we can call this image C a granulocyte. You can see that the nucleus is kind of curved.
Yes.
Yeah. So this is a granulocyte. So you can see the morula just beside it. So that is anaplasmosis. So C is anaplasmosis. B is erythrosis. So A is the typical rash that you see in the rickettsia. So that's spotted fever. So you can see that there are spots, everywhere and all those things. So by the time they even describe the rash, the progression of the rash, you'll be able to nail your diagnosis straight up. So the last one is Q fever. Q fever is one that we said is caused by Coxiella bonnetti. One thing about this guy is that this guy doesn't have any arthropod vector. He doesn't have any arthropod, that spread it like maybe tick, fleas, or something. He doesn't have. He doesn't have. So you get it directly from the reservoir. You get directly from the reservoir, you know, and it has no rash. It has no vector. So what is the reservoir that we talked about? We said droplings, urine, fecal matter, amniotic fluid from the sheep or from cattle. That's how you get Coxiella bonnetti, and it's a cause of what? Pneumonia, because we said that we are going to inhale the aerosol from the sheep or the cattle amniotic fluid, and the person will present with symptoms of pneumonia. And we said that it can also cause some inflammatory lesions in the liver, causing hepatitis, and it's also a common cause of culture negative infective endocarditis. I hope we're able to get the constellation of findings for Costello Bonetti. Hello? Hello? You guys are not answering me. Yes, I can hear you,
Okay.
Dr. Francois. Please, where did I stop?
Last thing I heard was something about pneumonia from.
Hello?
Hello, Dr. Babali.
Yes. So what did you say, Dr. Francois?
Can you hear us?
Yes, I think I can
I'm
hear you.
saying that the last thing you talked about was yes, so the pneumonia from Q fever because of inhalation of the aerosols.
Exactly. So they can inhale the aerosols. Then we also talked about it going to the liver, causing some inflammatory process in the liver leading to hepatitis. Then we said it can also affect the heart, causing culture negative endocarditis. So it has no vector, there is no tick, there is no flea, there's no louse that is transmitting it. So you get it from the reservoir directly. So once the reservoir passes out the excreta or the feces or the amniotic fluid, you know, the person can inhale it from there and develop the condition. So Coxiella can also survive outside, the reservoir as an endospore. So it can survive as an endospore within this. That's not how you so it's just one of those things that is just mentioned. So we should always remember the triad of Coxiella bonnetti: infiltration of the lungs, pneumonia, hepatitis, and endocarditis. I think we should be able to remember that, guys. Hello? Can you guys hear me?
Yeah, we can hear you. So you said pneumonia,
Mm-hmm.
endocarditis, and hepatitis, right?
Hepatitis, yeah. That's Coxiella bonnetti. Q fever. Okay. So it can cause Q fever. That Q fever is the one that causes the pneumonia. That's the pneumonia. But sometimes it can be combined with hepatitis. So the endocarditis is separate from there. I'm just mentioning that it can also cause endocarditis too. I hope you guys get what I'm saying. So what I'm saying is, if somebody has Q fever, it's majorly pneumonia-like presentation, but it can be combined with hepatitis. But the organism, which is the Coxiella bonnetti, can also cause endocarditis. So endocarditis is not actually the Q fever. It is separate.
Okay, I get it. So the Q fever is mainly the pneumonia.
Yes, pneumonia. but which can coexist with hepatitis.
With hepatitis.
Exactly.
Okay,
Exactly.
makes sense.
So, um, Mycoplasma pneumoniae is another one that we also been talking about. So, we said that this is an organism that lacks cell wall, just like ureaplasma. You cannot gram stain it because of that. Um, it typically causes atypical pneumonia too. So, just notice the person coughing, having headache, myalgia, malaise, and all those atypical symptoms. That is usually insidious in onset. So, it starts gradually. If you do your X-ray, you are going to see a diffuse patchy opacity or interstitial infiltrate. What it means is that they are affecting almost all the lobes of the lung. So they will affect the upper lobe, lower, middle, but it's not as if it affect the whole of that lobe. Like it doesn't affect the whole of the upper lobe, whole of the lower lobe. No, it should just affect them in a patchy distribution. So patch, 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 but it's diffuse. It's kind of touch all the lobes, and it is concentrated more within the alveoli, the interstitial space of the alveoli. That's why they call it interstitial infiltrate. So once you see diffuse interstitial infiltrate, you know that you are likely dealing with an atypical um, pneumonia. So that is it. So yeah. So mycoplasma pneumonia typically affect people that are young and adolescent, so less than 30 years, and it's very common in um people in close contact, like people in barracks, people in prison, dormitories, and all those things. You know, they can get exposed to the mycoplasma pneumonia from the aerosols. They can transmit it from one person to another because of that. So, aside the fact that it lacks cell wall, it contains cell membrane, and that cell membrane is rich in sterols that is there to maintain stability. So I've seen a question like that the answer is mycoplasma pneumonia. So maybe because of the fact, okay, they were asking why doesn't it respond to antibiotics, the penicillin. So it's because it doesn't have the cell wall. So not because it contains steroids. So some people can see this option there that the bacterial membrane contains steroids. So that is one of the features of mycoplasma pneumonia. But the steroids are there just to make it stable, just to give it this stability, support the structure of the organism because it lacks a cell wall. So the typical culture, or the agar for Mycoplasma pneumonia is the 18 agar. So the eating agar is the agar for Mycoplasma pneumonia. We might have forgotten, but that is important. Then, because of the fact that it is, one of those causes of atypical pneumonia rather, um, we said that sometimes, if you do your X-ray finding, the X-ray finding is not in keeping with the presentation. So that person can be walking, can be very much alive, and we are going to see so many infiltrates, so many bad things on the X-ray. The X-ray is going to be very, very terrible compared to the presentation. So that's walking pneumonia stuff. So the X-ray appears very bad, very severe compared to the present presentation. And this condition has some association. Number one, it can be associated with some rash, typically erythema multiforme. So I want to mention it now that erythema multiforme is just very similar to erythema migrans. Both of them can form a target lesion, but one way you can separate them is by looking at the implicating cause. So if you are seeing drugs, you are seeing mycoplasma pneumonia, you are seeing other things, some viruses, you know, that that's likely to be erythema migrans. So drugs, infection like mycoplasma pneumonia, you know, that is likely to be erythema migrans. But if it is from your Lyme disease, if the aperitif scenario of Lyme disease, you know that is likely to be your erythema migrans. So you are seeing arthralgia, you are seeing facial nerve palsy, we are seeing BCNS manifestation, then exposure to uh the exotic stick, we know that okay, that rash is likely to be the rash of erythema migrans for Lyme disease, because both Lyme disease, erythema migrans, and the erythema multiforme appears as targetoid lesion. But this erythema migrans can actually evolve to that targetoid lesion. So they usually start at red patches. So you just see the lesion appearing like a red patch. Then later they will change to the bull eye lesion. So don't be confused. Don't be confused that maybe we said that targeted is only for Lyme. No, it can be for both erythema multiforme, which is one of those rash that you can see in someone that has mycoplasma pneumonia infection, as well as Lyme disease. Another thing about this mycoplasma.
Dr. Babale, sorry, with the lesions, but with erythema migrans, don't you have it, as the name implies, it's a migrating lesion, so it might be at one part of the body at one time and then in another part of the body. Isn't that typically what happens?
Yeah, but it's very unlikely for them to give you that in the history that is migrating. Yeah, from the name, you can think that, but you are going to see this erythema multiforme in different part of the body too. So, that's one thing. It's not actually like a
Isn't
clincher.
erythema? I thought erythema multiforme was multiple lesions all
Mm-hmm.
at once, and then migrans might be one or a few lesions
Not
that
progressing.
move.
Yeah,
That's
so
how I think about them.
yeah, so if you see that in the option, if you see that in the question, that can also guide you. But what I'm saying is, majority of the time, you might not see it that way. They might not tell you that the rash is migrating. They might not. But if they say it,
Okay.
it can be a pointer to erythema migrans.
Yeah.
I
All right.
just I
Thank
just
you.
pray we see a question that can help us, separate both of them.
Mhm. Mhm.
Yes, yes.
Okay.
So, yeah. So another thing I want to mention is that Mycoplasma pneumoniae is associated with high titer of this cold agglutinates, particularly IgM. So that is why Mycoplasma pneumoniae can cause the cold autoimmune hemolytic anemia, because they have high values of this IgM that can agglutinate red blood cells and cause their hemolysis. So we've seen a question like that we were talking about, putting something in the code and the stuff accumulate agglutinated. And do you guys remember that question? So that we are linking
Yes.
to mycoplasma. Yeah, so we should not forget that. So mycoplasma forms cold agglutinin that contains IgM that can easily bind to antigens of red blood cells and agglutinate them, causing the autoimmune hemolytic anemia. Mycoplasma pneumonia has also been shared with Stephen-Johnson syndrome. So it can cause Stephen-Johnson syndrome. It can have the blistering, affecting all the body, even including the mucosa, affect everything. But it's less than 10%. So if it's more than 30%, you have toxic epidermal necrosis. But if it's between 10 to 30, you call that SGS TN syndrome. So yeah. So I think that's that about mycoplasma pneumonia. We should just remember that it lacks cell wall. It contains sterol within the cell membrane. It causes atypical pneumonia. It can be associated with some rash, like erythema multiforme. It can also cause other skin manifestations like Steven Johnson and Steven Johnson particularly. It brings about elevation of the cold agglutinins, IgM, that can agglutinate red blood cells and make them clump and hemolyze, causing cold hemolytic and autoimmune hemolytic anemia. So it's also common in regions where there is close contact, like the barrack, prison, the college. So what do you want to use to treat it? You want to use Doxy. It's one of those atypical organisms. So Doxy can work. Macrolide. So most of the time, where Doxy can work, your macrolide too can work there. So that's one thing to also take note of. Um, you know, look at chlamydia now. You can use Doxy there. You can also use azithromycin. Same thing happens here in mycoplasma. You can use your Doxy, you can use your macrolide, you can use your fluoroquinolone, but penicillin will be inactive against them because of the fact that they lack cell wall. So I think we are going to stop here. We'll move from the. I thought we were going to stop at the fungi today, but unfortunately, you know, we'll soon get to the viruses. So, okay. So, I think we are going to stop here, guys. So,